Hello everyone, I'm Nikki from OVAC. Welcome everyone. Today we're having a session about corneal topography, which will be presented by Randy Kojima from Medmont. I would like to thank the whole team from Medmont for helping us organizing this, and I hope you have a nice session. I give it to you, Randy.
Okay, thanks, Nikki. Hey, my pleasure, everybody, to be here and work with Nikki and Nick at OVA, and to be able to talk to you today about corneal topography and specifically the Medmont. You know, this is one of those tools that not all of us have in practice, but Nikki wanted to discuss today how you might use this instrument, how this might be able to help you in your specialty contact lens work. So it should be fun. We'll get an opportunity to look at the various applications that this instrument has in practice. Now, to begin, let's get right into it with a couple topographies. Now, clearly, this eye, or this pair of eyes, is keratoconic. And it's pretty obvious to see where the cone is and that it's a relatively moderate to advanced cone. But what would tell you specifically that this is a cone if you weren't looking at the topography itself? Is there some numbers on the screen that would help us? And one of the easiest things to do is to just look at the scale range here. Look at the amount of power distributed across this eye. And in this case, from the flattest we can see, right here in this dark blue, we go from 34 diopters to the steepest we can read, 61 diopters. So that's about a 27 diopter range of power distributed across this eye. Now, normal corneas have about 10 diopters. So right off the bat, we're clear that this eye is definitely off the scale in terms of curvature. Could we fit this patient with a corneal GP, or could we fit this patient with the soft lens? What would work for this patient? And you might look at the amount of power within the pupil, and we see this patient goes from beyond 60 diopters to somewhere around 38 or 9 diopters. So from 39 to 60, just within the pupil, there's about 20 diopters of power. So it would be unlikely that a soft lens would be able to manage this type of irregularity with the pupil. So the topography gives us some relatively simple stuff that takes us well beyond what a keratometer would give us to help us direct us in the right direction. Now, in terms of the disease, instruments obviously give us some indication of the type or degree, the magnitude of irregularity, and we can look at the disease detection indices here, the IS, the SAI, and the SRI values. And each one of those boxes is all lit up in red, indicating this is abnormal. If it were yellow, that would be of concern. If it were green, it would be normal. So the disease detection indices are all saying this is definitely an abnormal eye. And this can be helpful when you have a patient that's interested in refractive surgery and they would like you to refer them off to have surgery done. And this would be a patient that most certainly would not be a good candidate for any kind of additional thinning of the cornea. Now, the axial interpretation is one of the principal diagnostic analyses that we would use. And what the axial does is it gives you an understanding of the powers that are distributed within the pupil. So you can see that here from the inferior pupil, we go from 61 diopters curvature to 38 diopter curvature. So a 23 diopter distribution of power within the pupil. If we look down here at the graph, this darker gray area is where the topographer measures the diameter of the pupil. And we see this massive curvature change or power shift within that small area. So clearly this patient would struggle with glasses or conventional soft lenses. We would need some kind of specialty contact lens here to provide any kind of quality of acuity. Now, the tangential map is another interpretation. If axial helps us to appreciate vision or power, tangential helps us to appreciate shape. And one of those things it can do is it can assist in measuring the size, the shape, or position of the cone. In this case, we have a relatively small 3.3 millimeter cone. We'd consider this an oval or medium-sized cone as opposed to a globic or keratoglobus, a large diseased area. So this would be considered fairly normal. Now, tangential maps can be valuable in telling you if you have corneal molding. So if you fit this patient with the corneal GP and you're curious, has this lens fit this patient ideally? Do we need to alter the fit of the lens? You could pull up a tangential map and see if there's rings or arcuate areas in the corneal surface that would indicate that a contact lens has altered eye shape. Now, the elevation map is one that we don't use with great frequency, but it actually has a lot of value. The elevation map tells you where the eye is high and where the eye is low. In this case, we see the eye has about 310 microns of elevation, or the highest point on the surface along this white axis line is approximately 310 microns up, or increased elevation, whereas this inferior point is 290 microns below the elevation sphere, below the reference point. In other words, this eye has a 600 micron change in elevation from the highest point, 310, to the lowest point, 290 microns. And it's been found that when your elevation differential is greater than 350 microns, and we're at 600, then a corneal GP is going to struggle to work. So this is where Nikki and Nick and the team at OVA will decide that maybe Scleral might be a better option for this patient, that corneal GP is going to have a very difficult time dealing with the asymmetry of this eye. So the elevation map is a very helpful analysis in understanding where the eye is high and where it's low, but also the magnitude of that elevation differential. Now, one of the things that I think is particularly valuable in corneal topography is the ability to model the fit of a contact lens. So in other words, rather than going to my diagnostic closet and pulling out one of those billions of contact lenses that we have back there and placing it on eye, finding out it's too steep or too flat, pulling another lens out, going through that long process of cleaning the lens, getting it a bit hydrated, getting it ready to apply, putting it on, waiting for it to equilibrate, and then finally getting to analyze it. What the contact lens software does is it allows us to create a theoretical pattern, allows us to model how that contact lens might land, how it might lift, whether it's appropriate, whether it's inappropriate. Should we go with a different direction than corneal GP as an example? So it gives us the ability to place a lens on and determine across the flat meridian of the eye, do we have good, healthy landing on opposing sides? Then conversely, along the steep meridian of the eye, what kind of relationship does this lens have with the eye? Are we going to have excessive inferior vault? Are we going to have excessive vault within the pupil that would cause a bubble to form or a loss in visual acuity? Are we going to clear over top of the cone? So all very valuable things that the topographer software can provide. Now, another thing that we can do is we can actually place a scleral lens on the patient and do the same kind of modeling. drop that lens onto the surface, let it sink into the soft, boggy conjunctival tissue, and determine, do we have enough apical clearance, and have we cleared all the corneal tissue? So this contact lens software may be the most powerful tool that a topographer provides us in contact lens practice. I feel that I am far more efficient using the contact lens module than by using the diagnostic set. And it makes sense because we can put on a lens, we can alter the fit in this digital environment that takes us literally seconds to steepen or flatten the base curve, to increase or decrease the diameter. In the amount of time that we can model what might be the best possible fit in this contact lens software, I can't even finish cleaning the lens and placing it one single lens on eye. So it's a very efficient tool in contact lens practice. Now, for this particular patient, Scleral makes the most sense because we saw the elevation differential at about 600 microns. So this particular eye had a change in elevation that was far beyond what a corneal GP could manage. And when we place this patient into a scleral, we clear over top of all that irregularity. We land the lens way out on the conjunctiva where this eye is relatively symmetric. Then we're able to create the landing that we desire, but the appropriate vault with the cornea. So the topographer led us in the direction that a corneal GP probably wouldn't have been the best call for this patient, or certainly wouldn't have been the easiest fit, and that scleral looks like it would have been an easier avenue to follow. Now, there's various ways you can capture with the Medmont, and this is one of the reasons why why OVA loves this topographer and why it's favored worldwide as the gold standard in specialty contact lens topography. You can take a single topography image, which allows a pretty large area of capture. But what Medmont can do is something called a composite topography, which allows you to image 100% excuse me, of the visible iris diameter. So the Medmont is able to get the largest corneal coverage of any Placido topographer on the market. Another thing the Medmont can do is video topography, so recording video of the Placido reflection, so you can observe where there's tear film breakup. Then there's also a dedicated tear film analysis capture. So there's various captures that the instrument does. It's not just one single topography capture. Now, when we take a single map capture, what we're doing is one single topography of the cornea. And this would be an example where we've taken an image of a keratoconic patient, and you see this incredibly large surface area of capture. On this steep cornea, this diseased eye, we're getting over 10 millimeters diameter of information. But you do see some iris out here in the periphery that we're not able to image. And Placido simply can only go so far out, especially if the cornea is steep and especially if we have a large cornea. And although the Medmont as a small cone topographer has one of the largest areas of capture, we do miss some of the cornea. And if we're fitting a big contact lens like a scleral, it would be nice to understand the peripheral corneal and limbal shape. So the way around it is something called the composite topography. And this is a distinct advantage that Medmont has over all its competitors in that we can image the peripheral cornea. So using the composite feature, this allows us to take images in all of the principal directions. So in other words, we would have the patient look right down the axis of the instrument at the center ring, we take a photo. Then we have the patient look 1, 2, 3, 4 rings toward the nasal side, and that pushes the rings to the temporal side. Then we have the patient looking temporal, 1, 2, 3, 4 rings. That pushes the rings to the nasal side. Then we have the patient look down, and that pushes the rings to the top of the cornea, looking up, pushing the rings down. Now, all those are converted into a colorized topography, and they can be merged together to form a larger view of this eye. So although this patient has a single capture that gives us about 10 millimeters of information, using the composite feature, we can get the full visible iris. And this becomes very important related to some of today's rigid contact lenses. As an example, the standard 9.0 diameter is used less frequently today. We're more often using a 10 or 11 millimeter diameter lens. So we want much more of that peripheral cornea. If we're using a scleral, then of course we want to use some of this peripheral corneal and limbal shape to best predict the scleral lens diameter and the scleral lens depth that we might need. So I believe so strongly in this composite capture and its value in all of our modern specialty contact lenses today. Now, another thing that we said the topographer can do is it doesn't just measure eye shape. We can take all these little points of data, these thousands and thousands of points that the instrument captures, and rather than determine the shape of the eye, what if we were to look at the surface smoothness of the tear film? And what I mean by that is multiple studies have shown how using video keratostopy or using a reflection-based topographer, a placido-based topographer, to analyze the tear film can help us to appreciate the quality of that tear film and the tear film breakup time. So the TFSQ, or tear film surface quality capture, allows us to take a period of time right after the blink to determine how good is the tear film and for what duration. Then at what point does the tear film break up? So as an example, what we're showing here is not the shape of the eye, but rather dark blue is highlighting for you where the tear film is ultra smooth. From one point to the next point of measure, there isn't a elevation change. The tear film appears very smooth. Where you see hotter colors, that's where the elevation of the tear film is changing. And what we can see on the graph is the blink would be along this meridian here, and then right after the blink, the video begins. And we see the tear film is relatively stable for about 3.2 seconds. Then the tear film begins to break up, and there is a definitive breakup time at around 5 seconds. And then as you notice the duration going on in seconds, the tear film continues to show its distorting or breaking up. So your reflection-based topographer doesn't have to just be a tool for measuring eye shape. It can also be a diagnostic tool for determining non-invasive tear film breakup time, as well as the overall quality of the tear across the entire surface area that's measured. So why the Medmont topographer? And you may wonder, is OVA really into selling topographers, or are they a contact lens distribution company? And the answer is they're both, but really they use the Medmont because it is the preferred topographer of specialty contact lens practitioners. And hopefully I made a little bit clear to this point that the ability to measure 100% of the cornea is so critical to today's modern lenses. We're just not fitting small diameter GPs anymore. We're fitting much larger GP lenses. So we want a larger view of the eye. And the Medmont is the only placido-based topographer that will give us 100% of the cornea. then that can be converted to elevation. And once we understand the height of the eye, then we can drop a corneal GP on, we can drop a scleral on, and that helps us to choose the right first lens. The instrument also has very powerful contact lens software related to orthokeratology, which we're going to discuss in a second. And then, as we said, we can do tear film analysis. So really, it's why the Medmont? It's the Medmont because it is such a powerful tool in specialty contact lens practice. If your office is a very surgically oriented environment, then the Medmont is not the instrument for you. It does not measure the posterior surface, the posterior cornea. It doesn't measure pachymetry. So in that case, the Medmont would not be the right topographer. If you were looking for a simple screening device, one that does autocrays and auto refraction as well as a screening topographer, then the Medmont would not be the instrument that you want. But if your practice is more suited or more focused in specialty contact lenses, then the Medmont is the instrument that you want because it is so dedicated in its analysis and its construction for dealing with specialty contact lenses. So what Nikki wanted us to do next was to try to do a little bit more live rather than going through the didactic slides. Why don't we actually look at the Medmont contact lens software and see if we can have some understanding of how we use this instrument in practice. Nikki, can I get you to unmute yourself just for a second? Can you confirm that you can still see my screen and Medmont, the Medmont software is visible?
Yes, that's no problem. And just for the people also, there is a question box, so if you have questions, just go ahead, pop a question in the question box, and Randy will answer that at the end of the session.
Nikki, thanks a million for reminding me of that question opportunity. Much appreciated.
No problem.
Okay, everybody, so we've got a topography up, and how do we begin? If you're new to corneal topography, what's the first step? And I have to admit to you, when I first started looking at topography maps, I felt it was information overload. I was so accustomed to just having K readings as a analysis of eye shape. How do we begin when we have all of this data, when we have all of this analysis going well beyond that central 3 millimeters? There's a lot here, and certainly with all these pull-down menus, it can certainly be intimidating. Now, one of the first things that we want to do is we want to determine an analysis. Are we going to analyze or display this topography in terms of axial, tangential, elevation? We have all of these different analysis options. And what I might recommend, and Nikki would probably agree with me, that axial is one of the best ways to begin. Because what axial does is it explains to us how the cornea would contribute to vision. And as you know, about 80% of the quality of our acuity is derived from the cornea. And most powerfully, the anterior surface radii or shape of the front of the eye. So looking at this colorized topography within the pupil, do we see a regular cornea? Is one side of the line a mirror of the other side of the line? Is this hemisphere a mirror of this hemisphere? Do we see a regular corneal astigmat? And this patient has a defined flat meridian and a defined steep meridian, and they're 90 degrees apart. So we would say that this is a very regular cornea. This patient with spherocylinder refraction, with glasses, with soft lenses, with any contact lens should have excellent vision, because the anterior surface shape is so optimal for bending light. So that's one of the first things that we might look at is, with the axial map, do we see a regular corneal shape or an irregular corneal shape? Now, this patient just removed a soft lens, and maybe it was a silicone hydrogel lens with a high modulus. Is that lens molding the eye? Well, the axial map is not very sensitive to a finite point of curvature change. So this is where you might switch to a tangential map. And what we want to look for is, do we see anything in the surface, like any arcs or any high points next to a low point that might indicate that the cornea has been altered or molded by a mechanical force, by a contact lens? And we don't see anything obvious here that would indicate this patient has corneal molding. If we take this white axis line here, the eye seems to have a relatively smooth and gradual flattening from the center to the periphery of the eye. So nothing too interesting in the tangential map. We might switch over to the elevation map. And this is one that tells us where the eye is high and where the eye is low. And as we said, red is where the elevation of the eye is high. Blue is where the elevation of the eye is low. So if I click my cursor in this red, you see the elevation is plus 142 microns. If I click my cursor down here in the dark blue, we see the elevation of the eye is minus 71. So there's a shift in elevation of about 150 microns roughly, down to minus 70 something microns down here. There's an over 200 micron shift in elevation from this point to this point. So that's relatively high. And what that's telling us is that if we were to place a corneal GP on this patient, the corneal GP would land where you see red, and it's going to lift where you see blue. And it may lift a fair amount because there's a big elevation shift from this point to this point. Now, if you do orthokeratology, if that's one of the treatments that you have in your practice, then you might ask, is this a patient that would be a good candidate for a orthokeratology lens? Or if I was interested in fitting this patient in a multifocal rigid contact lens, would this be a good candidate? Do we have good opportunity to fit this patient with a symmetric lens, or is this eye relatively toric and we would need a toric type lens or a toric periphery? So one of the things that I find particularly valuable is understanding the sagittal depth. And if we go to analysis and details, we can pull up the sag of the eye. Now, as you know, sagittal depth is a measure of the height of the eye surface, or the measure of the height of the contact lens. And literally every single contact lens that you will ever fit is based on producing or constructing the lens with the proper sagittal depth for the sagittal depth of the eye. If our sagittal depth of contact lens is inappropriate for the depth of the eye, then our lens is not going to fit properly. It's going to be either too steep or too flat. So if we can measure the sag of the cornea, then we can have an understanding of the sag of the contact lens we need. So what we might do is set our cord at, let's say, 8 millimeters diameter, and we're going to analyze the weighted average height of this eye, or the height, the sag of the eye. And across the flat meridian, we measure 1,091 microns. If we click on the steep, it measures 1,154 microns. So if I did my math right, that's 63 microns of difference in height between the flat and the steep meridian. So in other words, the height of the eye this way compared to the height of the eye across the steep meridian of the cornea is 63 microns different. In other words, 63 microns deeper this way. So if we were to place a rigid contact lens on this patient, there would be landing along the flattest meridian of the eye, but we'd have 63 microns of fluid here and down here. So this might be a problem because we have so much fluid underneath the superior and inferior portion of the lens that our ortho-K lens or our multifocal rigid contact lens or our single vision rigid contact lens will have this gap or this free space to rock back and forth. So this is a good example where the corneal astigmatism is relatively low, only 1.33 diopters of corneal sill, or approximately 0.3 millimeters of corneal astigmatism. So a very moderate amount of central corneal sill at 3 millimeters. However, this patient has a lot of peripheral corneal astigmatism, and it's that peripheral corneal sill that makes this a slightly more tricky eye to fit. So it's important that we not only look at the power of the eye within the pupil, we want to go much farther beyond the central cornea to understand where our contact lenses might land. Now, what if we were to fit this patient with a ortho-K lens? Let's model how that might look. If I were to select a lens, let's see how that lens might appear based on the fluorescein pattern. So let's place a diagnostic lens on this patient and let's determine if we are comfortable with the appearance of that pattern. So again, this is one of those ways that we can where we can diagnostically fit the patient without actually placing that lens on eye. So here's our contact lens with our landing at 3 and 9 o'clock, just like we predicted. However, in the vertical meridian, you can see the amount of fluid underneath the alignment zone here and here. So clearly, this patient needs a toric alignment of the periphery to best fit this cornea. This patient has limbus to limbus corneal astigmatism. Let's go back to that topography. And you notice that both the center of the eye is astigmatic, while also the peripheral cornea is astigmatic. You see the hot on one side along this flat meridian at 12 and 6 o'clock, or the steep meridian, I'm sorry. And then along the flat meridian, we have this flatter color. So we're seeing a astigmatism both centrally, but we're also seeing an astigmatism periphery. So if you were just using K readings, you would not understand that this eye actually would be a more challenging eye to fit because it's both astigmatic in the center and astigmatic in the periphery. Let's take another case, somebody that's slightly tougher, and put on a corneal GP on this patient. So here's a keratoconic patient. Of course, we might look at the disease detection indices here, and we see they're all lighting up in red. One of the most important ones that the surgeons rely on is the IS value. The IS index stands for inferior versus superior average curvature. And if we take all the powers of the cornea within the inferior cornea and average them out, compare that with all the powers of the superior cornea, and we see that this eye has an inferior cornea that's 6.78 diopters steeper down here than it is up here. In other words, the inferior cornea is much, much steeper than the superior cornea. And since keratoconus presents in the inferior cornea the greatest percentage of the time, around 90% of the time, we can use that as a guide for when we're dealing with an irregular cornea. We can look over here at the scale range, and this patient goes from 34 diopters to 53 diopters. So there's a 19 diopter distribution of power across this eye. Clearly, it's irregular. If we take our axis line and cut it through the greatest points of curvature change, we see this eye goes from somewhere in the neighborhood of 50, let's see, click our cursor here, 53 diopters down to around 35 diopters. So somewhere around the 18 diopter range of power just within the pupil. So it's unlikely that a soft lens will be able to mask this type of irregularity. But let's go over to the elevation map. Let's look at how challenging this eye will be to fit. And right off the bat, when you look at this axis line, let's take it to the meridian of greatest elevation change. And here we see a elevation of plus 309 microns, and down here a drop in elevation of 290 microns. So this patient has around a 600 micron shift in elevation. And we said that when the elevation differential is greater than 350 microns, that's where a corneal GP is typically going to struggle. So just for fun, let's put on a corneal GP lens and let's see how it might look. So let's place that lens on, let's model the fluorescein pattern, and let's determine if this lens could be an appropriate fit. First, I'll click my cursor in the center and determine the apical clearance. So when you have this white axis line right on the apex of the contact lens, you notice the TFC, or tear film clearance, is 61 microns. In corneal GPs, patients often start to lose visual acuity when the fluid is thicker than around 40 microns, and we're at 61. So this contact lens is already far enough off the cornea on the visual axis that we might be concerned about a reduction in visual acuity. If we click our cursor in this deeper pooling here, we're up to 102 microns, and a bubble can form at around 90 microns. So we have too much fluid under the apex, where at the visual axis, we have so much fluid within the pupil, we may just get a bubble underneath our contact lens. And most concerning is that just over the cone, we have inappropriate clearance. That lens is essentially bearing on the cone. So we need to steepen up this contact lens to get that lens off the cone to protect that diseased tissue. So let's steepen it up. And you'll notice on the graph down below, as I take this axis line around, that lens is bearing heavy on the cone. So we need to go steeper still. So let's continue to steepen the base curve, see if we can get that contact lens off the cone. So this is good. Now we have our contact lens clearing over top of the highest point, the diseased tissue. The trouble, of course, is that in order to clear that high point, we need excessive vault in the center. Now we're up to 96 microns in the middle, and over here inside the pupil, we're at 141. So this patient almost certainly would get a bubble underneath this contact lens. So within a few seconds, we can try on different base curves to determine, is there any hope of a corneal GP working on this patient? Clearly, we need to go so steep in order to clear over top of the diseased tissue that we create excessive vault over the center and just north of center, that we're likely to fail in vision and fail because we're going to get a bubble. If we were to go exceptionally flat to try to reduce the fluid under the center of that contact lens, let's see if we can get that down to under 40 microns of fluid in the center. And we're at 39. So now we have a just barely acceptable amount of fluid in the center. And just north of center, we're at 78 microns. We might not get a bubble. But the damage or the concern is that we're going to have this heavy bearing on the cone. This lens would decenter radically. This would be unsafe for this diseased tissue. This would not be a good choice in fitting the patient. So there's some very powerful stuff that we can do with the contact lens software in choosing the right first lens. In this case, the contact lens software says definitely do not fit a corneal GP on this patient. We're going to struggle to create the appropriate alignment. What we might consider is if scleral just wasn't the option, if the cost was prohibitive, if the patient was going to struggle with application and removal because we had an incredibly deep set eye, then we might consider a piggyback. And in this case, we can see if we go with a very steep base curve around 680, we can clear over top of the thin portion, the keratoconic area. We could fill in this space in here, this gap where we have the bubble, with a high plus soft lens. So we could use a piggyback system with maybe a +4, +5, +6 soft lens carrier, and then place our rigid contact lens over top. But with this kind of elevation change, 600 microns, my first choice would be a scleral lens. And I might just place the scleral lens in the contact lens software over top of this eye to model whether we have the right sagittal depth, whether we can clear over top of the cone, do we need to go higher in depth, do we need to go lower in depth. So the ability to place this lens on the eye surface is very helpful to us in figuring out, do we have the right contact lens? So here what you see is our scleral lens with 291 microns of apical clearance, and it's landing, sinking into the conj, the average 125 microns that the lens normally compresses the scleral tissue. So you've now placed a scleral lens, and we've gone well beyond the borders of the cornea. The cornea is likely at around 6 millimeters out, roughly. So your lens is vaulting all the way past the cornea at around 6 millimeters, and it doesn't touch itself down till around 7 millimeters from center, or about 14 millimeters diameter. And we see it landing and vaulting over top of all the corneal tissue. So if we wanted to alter the sagittal depth, if we wanted to go higher in sagittal depth, then you can try on a trial lens that creates more central vault. We wouldn't. This is really where we want to be at 300 microns, but if you wanted to put more depth on or less depth on, you can try that. And in literally seconds, we can see how this lens looks. Does it clear the cornea? Does it clear over the cone? And it's becoming apparent that we are getting relatively close to the cone with this much lower sagittal depth lens. We're at 76 microns of fluid. A healthy scleral fit should be at least 100 microns over the central corneal tissue. I'm more comfortable when there's 150 to 200 microns of fluid between the lens and central corneal tissue. So I think I'd favor going back to the 3800 micron sagittal depth. So you get some sense that we can use the contact lens software to help us determine the right first contact lens. Now, what if we were to do ortho-K? How does the topographer assist us in ortho-K practice? And one of the first things that we want to analyze is, do we have an optimal candidate for orthokeratology? When we click on the baseline topography, do we see a cornea that looks like it would be suited for placing into a rigid contact lens in the closed eye environment. So let's go back to the axial topography. And I think in diopters, so I'm going to choose axial power. And we see a relatively apical corneal astigmat. You notice that the figure 8 astigmatism is very much confined to the center of the eye. So that tells me that I can probably push out this astigmatism, both corneal and refractive, with an ortho-K lens. If I want to measure whether I need a toric periphery, I go to Analysis and Details. We set our chord at 8 millimeters. Why 8 millimeters? Because in an ortho-K lens, that's generally the point where the reverse curves end and the alignment curve begins. So where the lens should begin to touch itself down on the eye surface is around 8 millimeters. So we want to measure the sagittal depth, the second column here. We want to measure the flat, 1134 microns. Compare that to the steep, 1148. So there's only a 14 micron difference between the height of the eye along the flat and the height of the eye along the steep. Essentially, this eye is relatively spherical all the way around. So this is a very good candidate for a symmetric, non-toric type ortho-K lens. Now let's put this patient into treatment. And we're going to send the patient home with the lens, and we're going to analyze what actually happened. And this is where we take the baseline topography, compare it to the post-treatment topography, and do what's called a subtraction or difference map or comparison map. It's known by many different names, but ultimately what we're doing is we're comparing all 15,000 points of this topography before we did ortho-K to all 15,000 points of this topography after we did ortho-K. And we're going to analyze the difference. And what we first see is with an axial display, you notice the blue treatment area relatively well centered to the pupil. So overnight, this contact lens appears to be placing its effect or its treatment well centered to the central cornea, the visual axis, and the pupil. So far, so good. The bad news is when we click our cursor in the center, we have only 1.5 diopters or 1.46 diopters effect, but out here we appear to have more effect, 2.5 diopters. If I click my cursor here, 246, over here, 231. So there's less effect in the center than there is in the periphery. And ortho-K should work in the reverse. There should be the most effect in the center and the least effect in the periphery. But this is only one night of treatment. And as Nikki will tell you, ortho-K takes 7 to 10 days for full effect. So we need to wait this out and see what happens after the lens has its chance to create full treatment. Let's switch over to the tangential map. Remember, axial is how we understand vision. Tangential is how we understand shape or molding. And we might look at this red ring where the reservoir of the ortho-K lens is that pulls on the epithelial tissue, creating this ridge or this ring. And is that well centered to the pupil? And we might argue that it looks like the lens is relatively well centered. So far so good. After one night's effect, I think we can be pleased we're going in the right direction. So let's analyze this patient after a little more effect and see what happens. And now you see in the center, we get 2.3 diopters of RX change. There's more effect in the center. We get this beautiful blue treatment area well centered to the pupil. It's looking like we're in good shape. So in Ortho-K, you don't have to do a refraction post-treatment because the topography will tell you exactly how much effect you created, as well as where that effect was centered. Then we can go over to the tangential map, and we look at the red ring to determine, did our lens center in the closed eye environment? Because of course, analyzing an Ortho-K lens in the open eye environment behind the slit lamp is not where it works. An Ortho-K lens works in the closed eye with relaxed lid over top of the contact lens for a prolonged period of 6, 8, 10 hours of overnight contact lens wear. So this subtractive map is so important to you in your Ortho-K practice, but it's not just a function that you would use or analysis that you would use in Ortho-K. You can also use it to follow a patient with disease. If we see a patient this year and we suspect that this might be an early keratoconic patient, we can map the patient 6 months from now and compare 6 months ago to today and do a difference map. If it's all green, it means there's no change in corneal shape. In other words, this disease is not progressing. If we see a red area popping itself out, in other words, the cornea is showing steepening over time, then we know that this eye is altering in shape. So the subtractive map is valuable in Ortho-K, but it's also valuable in following patients over time. Should we be considering corneal cross-linking for this young kid that's showing some changes in corneal shape? So I hope that gives you some overview of what we've what we use the topographer for. And Nikki, I might just open up this section for any questions and any comments on your part, anything that you felt that we didn't cover very well or that we could have addressed. I'm interested in your thoughts.
I think from my point of view, it's quite clear. I don't know if attendees have questions. It's the good time to pop them in the question box from your GoToWebinar banner. Perhaps one question on, or perhaps a comment on the first case you displayed. For some people, this might look as kind of an early keratoconic eye because it's not a really symmetric toric eye. I don't know if you can pop it up again.
Let's find that first patient. So it was the absolute first case that we discussed?
Yes, the first case. Some people might think as there is a bigger or more important red portion down below of this eye, some people might think perhaps it's keratoconic eye. But if you look at the diopters and the relatively small, you can say it's not a keratoconic eye. But some people might think initially at first sight. I don't know what's your point of view on this.
Yeah, it's a great point, Nikki. Thanks for bringing that up. If we click our cursor in the center, it's 44.43 diopters, and then down here, it's 45.88, so a little more than a diopter difference in power, not exceptionally significant. Now, research has shown us over the years, and going back to the very early days of topography, that there may be lid force that produces flatter superior cornea, steeper inferior cornea. So it's very common for us to see in our topographies that the superior hemisphere has flatter curvature than the inferior, and the belief is that it's that constant lid force and maybe gravity too that's pushing on the cornea, pushing the cornea down to a degree, and it's been suggested that that's why our topographies show often more steeper inferior cornea rather than steeper superior cornea. sometimes in patients with really tight lids, as an example, an Asian patient with a smaller fissure, sometimes you see a little ridge, a steep portion up here that is simply from the position of the lid. And if there's great lid force there, that can create some molding over time and produce a cornea that's showing a slight steep spot up there, but very common for us to see this steeper inferior cornea. And if we look at the disease detection indices, you notice that they're all lit up in green. So this eye is at least mathematically is determined or is analyzed to be absolutely regular in eye shape. Nikki, anything else that that comes to mind? I mean, from your perspective, what is the value of topography to you? If you're going from Ks to topography, obviously that's a lot more information, but how do you use the topography maps that are emailed to you, and how does that help you to make your diagnosis of the right next step?
With K readings alone, it gives you an idea, but it doesn't give you the whole picture. So you can start constructing a lens based on Ks, but the outcome is less certain than if you have a topography. Once you have a topography, you have the whole image of the eye, so you can start building your lens, or you can start evaluating which route you have to take to, let's say, come to a good solution for that patient.
You know, here's a good example, and I think you kind of, to me, you really nailed it, Nikki, that if we take these two patients, one obviously normal, one obviously abnormal, and look at this inner 3 millimeter ring. Now, I apologize, everybody, if this inner white ring is hard to make out, but you have a 3 millimeter white ring, a 5 millimeter white ring, and a 7 millimeter white ring. The 3 millimeter would be approximately where the Ks would be measured from, or a keratometer would measure this eye. Now, this is really wild. If you look at the flat meridian of this patient, 4346 by 4479, there's approximately 1 1/4 diopters of corneal astigmatism. Now let's take our very advanced keratoconic patient and let's look at the K readings, 44 1/4 by 45 1/2 roughly. So there's 1 1/4 diopters of corneal astigmatism in both these eyes. And boy, Nikki, as you said, this is the limiting factor of K readings, that they describe in the normal eye that the eye is probably pretty consistent in the way it flattens. And when we have two distinct meridians of curvature, a flat and a defined steep meridian, it's pretty straightforward to guess the first contact lens that we need. But here we have a patient that also shows only 1 1/4 diopters of corneal astigmatism. But yet, would this be a straightforward case that we could predict the parameters of this lens based on K readings? And the answer would be no. It would be so difficult. Yet both these corneas have 1 1/4 diopters of corneal sill, because K readings have to take an average of this point and this point and this point and this point. So it's going to be limited in its ability. Hey, Nikki, it looks like we're at about an hour. Do you want to wrap it up there, or was there anything else that you wanted to address?
From my point, I see no question popped in, so I think I would to thank the audience for attending this session. Certainly also Randy and Chris from Medmont for hosting the session, and I would say thank you and have a nice evening.
Thank you very much, everybody.